As I said, this is not a very routine topic for me. So, I'm going to try and play the devil's advocate and address what are actually the dilemmas in robotic surgery for gynae-oncology and why the fuss about robotics. So, obviously, when we talk about robotics, we cannot neglect laparoscopic surgery. We have grown up on that. We know all the advantages. The drawbacks, of course, are the unnatural movements, the poor ergonomics, reduced degrees of freedom, which makes a very long learning curve to master certain procedures, and the bidimensional view, which the 3D systems which are there in laparoscopy do not necessarily compensate for. And we see that the learning curve for majority of the patients of the procedures is around 50 cases for the time taken for the surgery. For conversions, it's about 150 to 200 cases, and for complications, it's probably even more. So, very steep learning curve for laparoscopic surgery, and that's where robotic comes in. There is 3D HD vision, there is very fine dissection, high precision suturing, and all this adds to a shorter learning curve. There is, of course, the EndoRIS system, which gives us 6 degrees of freedom. There is complete tremor elimination and motion scaling, which ensures that there is very fine dissection. And of course, the vision system is top notch, which actually compensates for the lack of haptic feedback. There is 10x magnification, which probably is very useful in dissection, especially in gynae-oncology, like the ureteric tunnel. And most importantly, all the assistant surgeon arm as well as the camera is under the control of the surgeon. And that means that, of course, they say that the learning curve is short, but is it really true? I can say from my personal experience that the first two cases were very difficult in gynae-oncology, even though I was a trained laparoscopic surgeon and used to do at least 2 or 3 procedures every week. It was actually unlearning some of the things that we do in laparoscopy to finally get comfortable with the robotic setup. And then, of course, we start getting comfortable with the robot. But I was myself surprised that it was actually about 5 cases before I became comfortable with the robot and I started actually liking it. Having said that, the number of cases that we end up doing is very low because of cost constraints. Now, coming to the evidence, if we see endometrial cancer, we have enough evidence to recommend minimal invasive surgery. We had the GOG Lab 2 and the LACE study, which showed that the short-term outcomes were much better with laparoscopic procedure, very large patient pools, and very good long follow-up. And we even have certain studies which say that, in fact, doing open surgery for early endometrial cancer is actually harmful for the patient. This is another study from Korea, which is more than 5,000 patients, real-world data, which has showed that not only is the hospital stay and the morbidity and cost lesser in minimal invasive surgery, including robotic surgery compared to open. The subgroup analysis of robotic surgery showed that the survival for endometrial cancer is even better in robotic cases. Of course, the number of robotic surgeries in this were only 315 of the 5,000 cases. So obviously the subgroup analysis was not powered for it. However, we do have one randomized trial from our very own Dr. Somshekhar, which did a 50 patient case study or randomized trial, so to speak, with better short-term outcomes in robotic surgery. Obviously, it's not a very large study, so cannot read too much into that. But when we talk about cervical cancer, the evidence is not so encouraging. If we all know about the LACC trial where they randomized to open versus laparoscopic surgery, multicentric randomized trial, which showed that there is increased risk of recurrence, decreased disease-free survival and overall survival for patients which were done by minimal invasive technique. Of interest, only 15% of these patients were actually robotic. Majority of these were laparoscopic. There are also several criticisms of this study, including the surgeon preference, the low number of minimal invasive cases done in the institutes, etc. But we definitely have randomized evidence that minimal invasive may not be as good as open in cervical cancer. So to address whether robotic surgery overcomes these drawback of laparoscopic surgery. Two trials are ongoing. One is the RACC trial, which is looking at robot-assisted versus open radical hysterectomy. So it's a prospective multicenter randomized open label trial for early cervical cancer. Interestingly, they have also included 2A in this group of patients, and the primary endpoint is 5-year recurrence-free survival. It's ongoing, and the early results are expected in 2027. Then there is, of course, the GOG trial, which is a non-inferiority trial, multicentric randomized for FIGO stage 1A to 1B2, and the primary endpoint is 3-year disease-free survival. Interestingly, this trial has got very strict criteria for surgeon credentialing. They have ensured that there is no uterine manipulator to be used, and there is a mandatory MRI staging, which I think will give us very good standardization of both the groups to ensure that we have a proper answer. But this trial is going to take very long, and we are expecting the results in 2030. So, to summarize, we have endometrial cancer, which is definitely amenable for minimal invasive surgery and definitely robotic surgery, especially with the Firefly technique for sentinel node biopsy. And for endometrial cancer, it's still work in progress. The reason why cervical cancer, is this video going to play? So this is a sped up video of robotic radical hysterectomy, which we did recently, and this is an endocervical growth with 1B1, which was a very obese patient. I think BMI was 32, for which we decided to do a robotic surgery. One of the advantages of robotic surgery is, of course, that the conversion rates are lower, especially in obese patients. And you can see here that you have the assistant arm under your own control, which is retracting. The magnification is brilliant. That's the uterine artery being taken. And then comes the dissection of the ureteric tunnel, which I think, I have in the past done laparoscopic radical hysterectomies, but given a choice now, of course with the evidence, laparoscopy is very difficult to justify, but robotic surgery is something which we still consider for highly selected patients. So you can see the entire ureteric tunnel is dissected, and this is the parametrium being taken. Paracolpus, apologies, and the bladder dissection being done now. So the advantage of robotic is the vision and the complete camera control, and you can see that there is absolutely no staggering, no fighting of instruments. The newer X or XI is very, very good and very easy to learn. And it's also a good educational tool because the vision is very clear even for the assistants. You can also have two consoles. So I just pointed out the nerves out there. So the pelvic nerves are very easy to visualize in the robotic system. And then once the entire dissection is done for both the ureteric and the uterines are taken out of region, we of course can take the vaginal cut. Occasionally we use either ICG or methylene blue to mark the level of the vaginal cut if there is suspicion of involvement of the pharyngitis, although most of these patients would probably go for radiotherapy any which ways. Next comes the lymph node dissection. I prefer to do the lymph node dissection after the radical hysterectomy. And this is actually a breeze when you do it with robotic surgery. The control of the system is such that even a first timer would probably do it without any problems. The endorist really helps in these situations, and you can see that you have the monopolar and the bipolar in each hand, so in case there is bleeding also, it's very easy to control. I'm sure most of the audience out here is probably already proficient in these procedures, so not discussing anything new. And that's the final result. So, conclusion, I think robotic is going to increasingly invade into the surgeon's fields, whether we like it or not, and it's better that we embrace this technology and help adopt it to in our practice. Thank you.